This is what is looking like right now. How do you like it? Are you missing it? We are enjoying very nice balmy weather here. Lots of cool breeze and sometimes sunshine. Last couple of days there hasn't been much of a sun, but it's beautiful. So do you want to come back or do you want to stay at home? Anyone?
We want to come back.
Sure.
We want to come back, sir.
Okay. So when you come back, I hope it will remain much more comfortable than what it was when you left. But let's hope that the vaccines which are coming up will give us some hope of resuming the classes as early as possible with lots of safety precautions. But when you come back, we still would be required to observe the basic principles of mask, hand wash, and social distancing. These are the three prime ways by which you can prevent almost all respiratory tract infections. So corona has helped us in reducing the load of other respiratory tract infections, particularly in those populations who have followed these three guidelines. Those who have not followed, unfortunately, they are still succumbing, they are still suffering from many diseases, but overall, incidence of respiratory tract infections has dramatically reduced because of these three interventions. And I think it's a good learning lesson for all of us, not only healthcare workers, but for everybody else, that we must observe these precautions even after corona pandemic is over, so that we can protect ourselves from influenza, meningococcal infection, pneumococcal infection, streptococcal infection, lots of other viral infections which Deependra has talked to you about. So today we'll progress from here into another area, and that is one case which we will discuss, and that is the case of Smiley. Are you ready for this? So we'll first discuss a clinical case, and then we'll try to diagnose as to what is the etiological agent and how we can prevent and how we can treat. So here is Smiley. She is not showing her teeth like all her friends are showing, but you can see the smile in her eyes and the angles of the mouth. So do you like Smiley? Right. So Smiley came to us in the early part of this year at about morning 10 a.m. We run this municipal Sanjeevani clinic, and sometimes if someone brings their sick child or sick person over here, we do advise them and we do sometimes treat them and or refer them to other places. Smiley was brought by her mother. Smiley is about 5 years of age, stays in Lamachor area, goes to a Montessori school. So it's a first or second year of her schooling. She came with complaints of mild fever. Mother said that she is not looking well, she's looking weak, she is not taking interest in anything, and she is not eating well. Now these are very, very common symptoms of fever, lassitude, anorexia, weakness. They do not pinpoint to any anatomical diagnosis, nor do they pinpoint to any etiological diagnosis, but they say that there is something wrong, most probably an inflammatory process is going on in the body. To confirm our clinical suspicion, we examined her. We found that she is slightly feverish, not very high fever. Her pulse is 90 per minute. Now, for a 5-year-old child, a pulse rate of 90 per minute, is it normal or is it abnormal? That is for you to find out. Okay, so one question for you today is, what are the pulse rate ranges at different age groups? So you can take it from childhood, from infant right up to an adult, because mostly After the age of about 20, 25 or so, the pulse rate remains more or less constant. So you have to find out, because when you are taking a pulse of a patient, you have to compare with the normal range of pulse for that particular age group. So pulse 90 per minute in a child of 5-year age. Is it normal or abnormal? Because if it is abnormal, it will give us some clue. She has got a temperature also. What is the relationship between temperature and pulse? Does the pulse increase or decrease with rising temperature? Any guess? Can anyone comment?
Fever will increase pulse, I guess, sir.
Yes, almost every 1 degree rise in temperature should lead approximately to increase in pulse rate by 10 beats per minute. That's a rough calculation. So if you find that temperature is rising but pulse is falling, that means you have to have some list of conditions where this thing happens. Usually any fever should reach to rise in the pulse rate. She is lethargic, as mother had mentioned. There was no anemia, but there was mild congestion in the throat. Now we had seen mild congestion in the throat in some other cases also. You remember something? Earlier we had some one case where there was mild congestion in the throat, or Dipendra also must have told you number of conditions where there is a throat congestion. So all this is indicating that perhaps there is something wrong, some infection in the throat, which is leading to these generalized features. Cervical lymph nodes are palpable and tender, and you are very well aware now which cervical lymph nodes palpability shows which particular draining area, and it shows that what must be the site of infection. One second. इंस्पेक्शन खत्म भएर सबैले उता अफिसमा लिएर जानुहोस्, उता कफी राखेको छु. So a presumptive diagnosis of throat infection was made, and it was considered that most probably it's a viral infection, and so she was given some antipyretic and some antihistaminic to relieve the symptoms. No antibiotics were given. Okay, so that happened on 12th January, 10 o'clock. Now, same night at 8 p.m., the mother brought the baby to MTH because she thought something is wrong with the baby. And she was not happy with the treatment which was given in the clinic over here. So at that time, again, the temperature was found to be 98.5, pulse was 100 per minute. So there was some change in the pulse rate. There was weakness of the limbs. She was quite lethargic, much more than what she was in the morning. The throat was congested, and when she was asked questions, she was not speaking well. A child who does not speak well could be either the child is shy or hesitant, or it could be because there is some anatomical or physiological problem in speaking. So if the child does not answer to your simple questions, if you think the child is not shy and is still not able to speak, that means you must look for local causes. And where does the speaking occur? Where does our voice come from?
Larynx.
Larynx. And tongue plays to a great extent a big part in our voice. And as you mentioned earlier, even the sinuses play a big part in making that particular type of tone or depth of the speech. So which particular component of speaking is affected will to a great extent tell you as to where the lesion is most likely to be. Now look at it. We have not embarked onto any big laboratory investigations. We have not done an X-ray. We have not done an ultrasound. We have not gone to CT, MRI or something. We're just simple scratching our brain and trying to put common sense in its perspective to understand what the disease could be. And 99% of the times, if you use your common sense and if you use your analytical mind and if you go in a logical fashion, you can diagnose cases in more than 90% of the cases by proper history proper examination and then interpreting those facts. The investigations should be there only to confirm or shortlist from your tentative 2 or 3 diagnosis into one diagnosis. So here, throat congested, not speaking well, that means perhaps there is some involvement of the larynx or pharynx. This is what we can guess. Again, she had no anemia, cervical lymph nodes were still found to be palpable tender. Since some patient has come on 12th January, that's middle of the winter, cold winter, 8 p.m. is almost like midnight in Manipal or in Pokhara. A patient coming at such time, you should be a little more careful for the simple reason that if the patient has inconvenienced herself or himself and the family has inconvenienced and have spent money to come to hospital, there must be something more than what meets our eyes. You should not be dismissive of such patients that, okay, nothing, it's only upper respiratory tract infection, take these medicines, go home, you'll be all right. Perhaps not, because that she had been given the same thing in the morning, but she has worsened over a period of 12 hours. So someone who was there in the emergency was much wiser, much sensible. So that person said, let's admit her for observation, keep her for observation and see how she is progressing. There is no need to send her home. We can keep her here for a few hours and let's see how she progresses. So that if required, we can do some intervention, because if she goes home and something goes bad, there might not be enough time for her to come back to hospital. Very wise thinking, very correct approach to patient management. Since she was in the hospital for observation, they took some samples. So TLC showed 18,000 total count with polymorphonuclear cells 78%. Urine did not show any abnormality, so they ruled out urinary tract infection. Blood culture was taken because they thought maybe there is some kind of a bacteremia or septicemia. So any fever patient who is not responding well, blood culture is important. Vidal test was not really important at this time, but someone wanted to see the base level of Vidal, base level of antibodies against Salmonella. It was a good thinking, because if the fever continues for 7 more days and they do a repeat Vidal, they can compare the titer and say whether titer is increasing, then there could be a suspicion of enteric fever. But enteric fever usually does not present with throat symptoms. So this was slightly overdone, but anyway, we can grant it. We are looking at it retrospectively, so we are analyzing it, but maybe at that time clinician thought there might be possibility of enteric fever, so blood culture and Vidal test was done. What was most important one, which was very properly done, was since the primary site of infection was suspected to be throat swab samples were obtained. Now here comes something which I had asked all of you to do, was to examine the throats of the family members. Have you done that? Are you familiar with the anatomical structures which are seen in the throat? Are you familiar with their appearance during normal times? You need to be, because then only you can distinguish between abnormal and normal. And then you need to develop a habit of collecting proper throat swab. A proper throat swab is collected by rubbing, by first rinsing the oral cavity. Just patient is asked to rinse the oral cavity once, simply to remove any saliva. Then with a tongue depressor, the tongue is praised, mouth is opened, patient is asked to say ah, so that you can see the posterior pharyngeal wall. Take a throat swab or take a swab first on the both tonsils. Thereafter, the posterior pharyngeal wall where there is inflammation. Because if you touch the posterior pharyngeal wall first, the patient will gag and will not be able to collect any other sample. So first on both tonsils and then onto the posterior pharyngeal wall, telling the patient, hold on, don't cough on me, don't say ah and throw out, because it will cause little discomfort. And those swabs are collected and sent for staining and culture. Now, this throat swab is useful only for bacterial infection, not useful for viral infections. But if it is positive, it tells us a positive diagnosis. If it does not show anything significant, it rules out bacterial infection. So, throat swab is a very important investigation. The rising TLC is indicative that yes, there is some infection, and polymorphonuclear increase also tells us that most probably it is bacterial infection. Now, what happened? The patient was in the hospital, and on the same night, at about 11 p.m., the mother realized that child is having difficulty in breathing, sudden respiratory distress. The nurse on duty pushed in 2 tubes of oxygen in the nose and tried to deliver oxygen, but even then the child was very restless and was finding difficulty in breathing. Someone came in, put the stethoscope on the chest, and realized that there is not adequate air entry occurring in the lungs. I had asked you people to start using your stethoscope in auscultating the chest in listening to various breath sounds. Normal breathing, forced breathing, and various other sounds. So please practice on that, because that is what helped here this particular doctor on duty to understand that air entry is compromised, and then she looked at it and she realized accessory muscles of respiration are in action. Have you been taught about the muscles of respiration? Can anyone respond?
No, sir.
Okay, so now when the anatomists and physiologists will teach you about respiration, they'll teach you what are the bucket handle movements of the ribs, how the chest expands, how the diaphragm pushes down, and how normal respiration occurs, and how in cases when there is a forced respiration, accessory muscles come in action. So maybe it might be interesting for you to read about how the chest movement occurs and how it facilitates entry and exit of the air, and under what condition accessory muscles can come into play. Now, this is a very simple observation. You look at the patient, you see the patient's distress, you see which muscles are acting, and you have the diagnosis whether there is a blockage in entry of the air or there is a blockage in the exit of the air. Two entirely different pathologies. But if you have observed and if you have understood the role of muscles in respiration, you will be able to make this diagnosis. So, anatomy, physiology knowledge is extremely important when you are trying to diagnose a patient. Don't underestimate that. So, read about it. What are the muscles of respiration? How they act? What are the movements? And try and see them in your own body or in someone else's body as to how these things happens. So since accessory muscles were in action, someone realized that there is problem in the entry of the air. So there perhaps is some blockage in the passage of air. Over a period of time, they realized that she is getting cyanosed. What does it mean? Cyanosis. What does it indicate? Central cyanosis, peripheral cyanosis. But they realize cyanosis is occurring on the face. So it is central cyanosis. So what is the cyanosis due to? Anyone? Someone else, not the same person. Someone else?
Blood.
Deoxygenated blood. That means there is not enough perfusion occurring. So two diagnoses were made here, that air is not entering into the lungs, and because air is not entering into the lung, enough oxygenation of hemoglobin is not occurring. Very important findings just by looking at patient. And then when the pulse was taken, they found now the child is having tachycardia, 120 minutes per minute. It's irregular, the volume is low, child is showing mental confusion, which is a direct implication of cyanosis or hypoxia. Child is listless, agitating because she is not able to breathe properly. So all these are indicative that there is some problem in entry of the air leading to inadequate oxygenation leading to hypoxia, cerebral hypoxia, as well as hypoxia of other organs of the body. This becomes a life-threatening condition. Good that she was in the hospital, because if this had happened at home, perhaps at the night, 11 p.m. at night, she won't have been able to get any help in her village, and in the village perhaps there won't have been any vehicle or a taxi available for her to be brought to hospital. Prognosis could have been terrible. This is how Smiley was looking. No more smiling. You can see the swelling over here in the neck region also. And when the throat was examined, it looked like that. Now, in an agitating child, it is difficult to examine the throat. So some attempt was made to see what is obstructing, what is happening over there. And there was something happening over there. And that something was this whitish patch. So a diagnosis was made that there is some obstruction in the respiratory tree, air is not entering, and an emergency tracheostomy was done. Now here is a question for you. What is tracheostomy? What is the site of tracheostomy? How it is done? What is the purpose? Few things about tracheostomy I would suggest you people to read and understand, because this is one procedure which, if it is done in time, can save life. It's a simple procedure, but if it is not done properly, it can lead to death of a patient. After tracheostomy, oxygen mixed air was pushed into through the tracheostomy tube, and then they realized that over a period of time, the respiratory came down to 20 per minute, pulse rate also came down to 90 per minute. It was there earlier, but it is still irregular and low volume. So irregular pulse, low volume pulse. What does it indicate? There is something wrong with the heart. So we have had two anatomical diagnoses, something wrong with the respiratory tract, which was relieved by tracheostomy, but something was wrong with the heart, which was not relieved by tracheostomy. So there is something which is affecting both respiratory system as well as cardiovascular system, which was confirmed on ECG, which shows some changes in the T wave, some changes in the ST segment. And I'm sure in cardiovascular system studies, you have studied about ECGs. So you should be able to talk, you should be able to discuss as to what are the irregular pulse, what changes can occur in T wave and ST segment under different conditions. The person who did tracheostomy was smart. After tracheostomy, they could open the mouth very comfortably. They put another swab in the laryngeal area, took it from there, sent it for staining and culture, because by now they were more or less on to their clinical diagnosis of a very dreadful childhood disease. They also sent samples of blood for urea, electrolytes, etc. because when the patient goes into cyanosis, it means severe hypoxia has occurred. So not only oxygen, not only hemoglobin, but other organs also are likely to be damaged, particularly high volume working organs like liver and kidneys and brain, of course. So they sent these investigations to find out if there was any damage to kidneys also. Very good thinking by whosoever was the clinician at that time. So this was what they found out after good examination, and this looks like something patchy membranous material which is obstructing the respiratory tract. Can you see how narrow the tract has become? These are tonsillar areas, and this is covered over here, and it's blocking that. So this was the anatomical problem, and this was the etiological problem. So the gram stain from the throat swab from the larynx showed this gram positive bacilli in this particular fashion. Can you imagine something out of this pattern of arrangement of the bacteria? Does it look somewhat familiar with something? Anyone? Any simile?
Maybe Chinese writing.
Yeah, you can say Chinese, whichever language we don't understand, that they are in those languages, the letters, alphabets are with the strokes. So it looks like Chinese letter arrangement. You can see these two bacteria here, two bacteria here, two bacteria here, some cluster bacteria here like this. So these look like Chinese letter arrangement, which is quite characteristic of a condition, and that condition is called what condition? Which bacteria shows Chinese letter-like arrangement? So the clinical diagnosis was made before anything was done by the laboratory. A good clinical diagnosis was made that patient is suffering from an infection of Corynebacterium diphtheria, and the clinical condition is called diphtheria. The swabs which were sent to the laboratory, since the clinician was smart, clinician was good, clinician was intelligent, the clinician, when sent the swab down, put a clinical diagnosis of suspected diphtheria. It gave an indication to the laboratory as to which media they should be using and what tests they should be doing. As soon as they did the gram stain and they realized that there is a Chinese letter arrangement, they realized that it could be diphtheria as clinically suspected. So they put the swab on two important media, blood agar and tellurite agar. So on these, after 2 days, now imagine bacteria take time to grow. Bacteria cannot grow within 6 hours or 2 hours, but the clinical treatment is required within that time. So on blood agar, we found hemolytic colonies. We found black colonies. Now, this is the characteristic feature of diphtheria colonies on tellurate agar because it reduces tellurite into metallic tellurium, and metallic tellurium has got black color, and therefore the colonies look black in color. So question for you is, what are the selective media for Corynebacterium diphtheria? List the selective media, which is the important component of that medium, and how it makes the medium selective. Tellurite agar plate contains potassium tellurite. Since we are taking a throat swab, the throat swab is likely to have many organisms: Streptococcus, Staphylococcus, Haemophilus, maybe many other bacteria, and they all can grow on blood agar. But we don't want them. So we want only Corynebacterium diphtheria. So if we suspect Corynebacterium diphtheria, we use tellurate agar, where potassium tellurite inhibits all other bacteria except Corynebacterium diphtheria. But it is a selective media. Therefore, we also have to use another medium, which is blood agar, which will allow all other bacteria also to grow. Because if you use only tellurate agar and if it is not Corynebacterium diphtheria, we are going to lose any other organism. It could be Streptococcus, it could be something else. So a throat swab is always plated on blood agar, and in addition, depending upon the clinical suspicion, we can use another selective medium. A gram stain from the colonies showed similar Chinese letter type of organisms. They are pleomorphic and they are bent at particular angle, two bacteria lying together, giving the Chinese letter appearance. And when we did a spatial stain, Albert stain, we could see some volutin granules. So these were the colonies on blood agar, some degree of hemolysis around the colonies, and these are the black colonies on potassium tellurate agar, which is actually a blood agar along with potassium tellurate. So Corynebacterium require blood agar to grow properly, and potassium tellurate inhibits all other bacteria. This is how the Albert stain looks. Here the bacillus looks green in color, and at the end it has got a volatilin granules which stain blackish bluish in color. So very picturesque. And again, look at the arrangement of the bacteria. They are arranged like a Chinese letters or Japanese letters, with some of them are without volatilin granules, some are them with volatilin granules. Now these two diagram findings are very important. Yes, anyone wants to ask any question? These two diagnoses, these two findings are very important for clinical and laboratory diagnosis of diphtheria. But what are these volatilin granules or metachromatic granules? Which organism produce that? Can bacteria other than Corynebacterium diphtheria produce these granules? Well, I think this should be a question which you people should be answering. To find out what are volatilin granules or metachromatic granules, there is a small paragraph about it in your book. What is the chemical composition of these granules? What are the different stains used? There is Albert stain and there is Neisser stain also, which is used for staining them. And other than Corynebacterium, there are few other organisms which also can give these granules. But most of those organisms are non-pathogenic. So from a clinical case, when you identify volatilin metachromatic granules in the bacteria, 99% of the times your patient is suffering from diphtheria. So let's now talk about Mycobacterium, about Corynebacterium diphtheria. Okay. So Corynebacterium diphtheria are gram-positive bacilli. As we have seen, they are pleomorphic. Some could be short, some could be long. They may be arranged in a angular fashion or parallel to each other, giving a palisade fashion, or they may be at angles, which may give a Chinese letter-like arrangement. And they have a club shape. That means at one end they are slightly thicker and bigger. That is the reason they are called Corynebacterium. Corynea means club shaped. These are non-capsulated, non-sporing, non-motile, and non-acid fast. So lots of non things in that. But one important thing is that they would contain metachromatic granules on Albert's or Neisser stains. So that's the morphological description of Corynebacterium diphtheria. They would grow at body temperature, that is 35 to 37 degrees centigrade. Presence of carbon dioxide helps them grow. So 5 to 10% carbon dioxide is useful. On blood agar, they form hemolytic colonies, while as we discussed on potassium tellurite medium, they form black metallic colonies due to reduction of tellurite into tellurium. There is some additional medium which is used for isolation of Corynebacterium diphtheria, and that's called Loeffler's serum media. It could be a liquid or it could be a slope. Usually we use it as a slope, Loeffler's serum slope. Now Loeffler's serum slope is a specialized medium which allows rapid growth of Corynebacterium diphtheria. They may take 12 hours or 18 hours to grow on blood agar, but on Loeffler's serum slope, they will grow within about 6 to 8 hours. So this is a very good medium for an early diagnosis of Corynebacterium. This Loeffler's serum slope does not support most of the other bacteria. They will not grow so rapidly as Corynebacterium diphtheria grow. And if the colony grows over there within about 6 to 8 hours or so, we can do a gram stain, we can do an Albert stain, demonstrate the morphology, and can confirm the diagnosis within few hours. So use of such media is useful for rapid diagnosis of diphtheria. The biochemical reactions, since this bacteria is fastidious, it requires serum in addition to the biochemical sugars. So we do fermentation tests in serum sugar, and we can do a glucose and maltose fermentation, and then we can diagnose this to be Corynebacterium diphtheria. You don't have to remember as to which bacteria we use which acid positive and which sugar fermentation, but just remember that the medium required is a serum sugar set. The Loeffler's medium contains serum, the sugar set also contains serum, and the solid media contains blood. So being a fastidious organism, it requires these nutritional requirements. So let's review our patient. Patient came with sore throat, low-grade fever, swollen lymph glands of the neck. 3 clinical presentations which showed that there is an upper respiratory tract infection with involvement of the lymph nodes. Usually, of the lymph nodes indicates a bacterial infection. So, it is very important that you examine the patient's cervical lymph nodes, and depending upon which lymph node is involved, you look back into that anatomical part of the throat to see where the infection is occurring. Patient had developed tracheal obstruction due to the pseudomembrane, and we had relieved that pseudomembrane by doing a tracheostomy. We relieved the obstruction, the pseudomembrane remained there, but we overcame that obstruction by creating a bypass. But as we had seen, it had effect on other parts of the body also, and those were, there was effect on the heart because we had seen bradycardia, we had seen irregularity of the pulse, we had seen ECG changes. There were some damage to the nerves also, adrenal glands also, as well as kidney, which was revealed by urea and creatinine levels. In other words, we had an infection of the throat with systemic effects and anatomical blockage of the respiratory tract. So we had mechanical blockage and we had systemic effects. Now this happens in Corynebacterium diphtheria infection. How does it occur? How does it spread? Is that human beings are the only carriers of Corynebacterium diphtheria. So we all can harbor Corynebacterium diphtheria in our throat, adults as well as children. And like COVID, the bacteria are expelled in our respiratory droplets when we speak, when we sneeze, when we cough. They are expelled over there and they may drop down on various parts. They may fall down on our hands, they may fall down on our laptop screen, they may fall down on our tables or anything else around. And from there, they can spread to another person. The another person may inhale and get them back into the throat where they will colonize and they'll start their function, or sometimes it might occur deposition on the skin. So we can have cutaneous diphtheria or we can have respiratory diphtheria. Interesting. An organism which primarily lives in the throat can also cause cutaneous infection. This bacteria is influenced to a great extent by the presence or absence of iron, and its replication depends on the iron. So it grows very well on iron containing medium, but it can grow and produce toxins on non-iron containing medium also. Now what role does the toxin play is interesting to see. The toxin causes destruction of the cells, not bacteria, but epithelial cells or other cells in the body. And what it does is that by destruction of the cells, it is releasing iron molecules which the bacteria can imbibe. So, production of toxin is one of the ways by which bacteria make sure that it gets adequate nutrition. The bacteria can evade the host immune response because it gets firmly adhered to the epithelial cells. Now, if the bacteria is stuck tightly to the epithelial cell, it is difficult for the phagocytes to take it out and eat it away. And then the bacteria produces a toxin. This toxin can also kill the phagocyte. Now, dead phagocyte is lying on top of the bacteria. It protects the bacteria from attack by another phagocytes. So one molecule of toxin can kill the epithelial cell on which it is attaching. Another molecule can kill the phagocyte which it is trying to attack, and the bacteria can remain between the two layers of the dead epithelial cells and the phagocyte. And this way, large number of bacteria present like that will form a pseudo membrane formation. So what is a pseudomembrane? It is not a true membrane. It is not like a pleural membrane or peritoneal membrane or pericardial membrane or meningeal membrane. It's a pseudomembrane. It is formed by the dead epithelial and phagocytes with trapped bacteria between them. So therefore, it's called as a pseudomembrane, and it looks like a leathery membrane, something like the leather or chala, and that's why it is called diphtheria. Diphtheria means leather-like appearance. So the etymology, nomenclature of the bacteria comes as Corynebacteria because it is club-shaped, and diphthery because it forms a pseudomembrane which is leathery in appearance. And this pseudomembrane is the one which causes mechanical blockage to the respiratory tree. If the pseudomembrane is present on the cheek, it is not going to cause much problem. But if it is present on the pharyngeal wall, it is going to cause problem. If it is present on the larynx, it's going to obstruct the larynx. So depending on the anatomical position, if it is present only on the tonsils, maybe it may cause some discomfort, but will not cause respiratory embarrassment. So the anatomical position of pseudomembrane is very important in determining whether it will cause respiratory obstruction or not. And in our patient, the pseudomembrane was formed on the larynx. So it had obstructed the laryngeal opening and no air was going in. So this gives you one more task. Please study the larynx. Please study the aperture of the larynx. Please study as to how when we speak, how we talk, the larynx opens. When we breathe in, how the larynx opens. When we hold our breath, how the larynx closes. So the damage in case of Corynebacterium diphtheria occurs by two. One is by pseudomembrane, which causes a physical obstruction, and second damage occurs by the circulating toxin and the inflammation which occurs. The inflammation could be locally, so it adds on to pseudomembrane formation. The toxin goes into systemic circulation, spreads everywhere, and causes damage to different cells in the body. How the bacteria get transmitted? By aerosol droplets or by fomites. So as we have earlier discussed, the name Corynebacterium diphtheria is because of its shape and because of the leathery pseudomembrane that it forms. Why does the bacteria produce toxin? How does it produce toxin? What happens is, bacteria gets attached onto the epithelial cells. It's a non-motile bacteria, so it just remains over there. It gets stuck and it divides and multiplies. During its metabolism, during its process of dividing and multiplication, during its other metabolic activity, it produces some chemicals which we call as toxin. And this toxin kills the adjoining cell and helps the bacteria into getting its nutrition. So for bacteria, toxin production is useful for its multiplication. But this toxin causes damage to our local epithelial cells, as well as the toxin can get absorbed into the bloodstream and go to different parts of the body, and in different parts it can have effect on different cells of different organs. So diphtheria spreads from human to human. It's commoner in poorer areas because of overcrowding, but to a great extent we have been able to prevent the diphtheria disease because of mass immunization. But diphtheria bacteria can still survive in our throat even if one is vaccinated. So please remember, even a vaccinated person can be a carrier of diphtheria and can spread diphtheria, Corynebacterium diphtheria. And a person who is not vaccinated may get infected and may die because of effect of toxin. So the death or damage is as a result of exotoxin and not because of the bacteria itself. The gene of toxin producing is a phage, bacteriophage, which is present in some of the bacteria, which may be absent in some of the bacteria. So every Corynebacterium diphtheria which we isolate need not necessarily be a toxin producing bacteria. Now, if Corynebacterium is present in the throat and if it is not producing toxin, well and good, no problem. The bacteria can survive in our throat. We may be healthy, we may remain healthy, bacteria may also remain healthy, and it may get propagated by our respiratory secretions or droplets. No problem for anyone. It's a symbiotic relationship. But only when it starts producing toxin is where it causes problem. So the phage causes lysogenic conversion of the bacterial cell, and then toxin is synthesized as a single polypeptide chain, and that single polypeptide chain is released from the bacteria in the surrounding tissue, surrounding fluid, and from there it can travel to the adjoining cell, or it can get into the blood circulation in the lymph node, in the lymphatic, from there into the blood circulation and go to various places. And the lower concentration of iron stimulates the phage, stimulates the bacteriophage, and causes more production of toxin. So that's why we think that by producing toxin, the bacteria is making iron available to it by killing the adjoining cells. What is this toxin? The toxin has got two components, A and B. In fact, you remember for most of the exotoxins, there are two components, A and B. The B component is for binding, while A component is for action. So all toxins will have two components, A and B. B is for binding, A is for action. Now B binds and allows the molecule to enter inside the epithelial cell, and this A component, which is released in the cytoplasm, interacts with the ADP ribosilate and elongation factor 2, EF2. This elongation factor 2 is inhibited, and therefore there is no protein synthesis or decrease in the amount of protein synthesized. And since protein synthesis is essential for cell maintenance, the cell ultimately dies. And when the cell dies, it releases iron, which that iron is useful for the bacteria to grow. Now the toxin is very potent, that one molecule of toxin can kill one epithelial cell. One molecule of toxin can kill one phagocyte. So 1:1 ratio of the toxin molecule and the cells. It's very potent toxin. So here is a diagrammatic representation. Consider this as a toxin molecule composed of A and B parts. B parts attaches to the cell, and then the toxin molecule enters, and this A component is the one which actually starts its activity, and it inhibits the elongation factor plus NAD activity, and therefore it reduces the protein synthesis. So this is how the toxin enters and toxin acts in case of diphtheria. So let's look at pathogenesis. As we have seen in our patient, there was local invasion and pseudomembrane formation which led to obstruction. So this is one type of pathogenesis, physical obstruction to respiratory tract. The second pathogenesis is effects of the toxin. The toxin has effect on the heart muscles, so it is cardiotoxic. It has effect on the nerves, neurotoxic. It has effect on the adrenal glands. So all three effects are there, and all these effects are because of inhibition of protein synthesis. Depending upon where the toxin has acted more, we can have some features where there could be more of a cardiotoxic features, there could be some more neurotoxic features, or there could be failure of adrenal gland. And I think you have already studied about the adrenal gland, so you should be able to tell me when the failure of adrenal gland occurs, what will be the clinical features, what is that condition called. Can you go back? And can someone tell me what are the effects of failure of secretion of adrenal? What do the adrenal glands secrete? Where are the adrenal glands? Anatomical location?
Suprarenal.
Suprarenal region. It has got two components. Which two components?
Cortex and medulla.
Very good. So it produces different hormones which have got multiple effects in our body, and these hormones are extremely essential for our health and survival. A failure of adrenal gland can lead to severe hypotension and death. So depending on whether the toxin is acting on the heart muscles or on the nerves or on the adrenal glands, we can see clinical features, and these effects can remain for long duration. The nerves, the heart muscles or the adrenal glands which are damaged because of the toxin will take a long time to regenerate and come back to its normal position. Therefore, we can have patient of diphtheria suffering from diseases much later than that acute attack. So how do you diagnose diphtheria? First and foremost, on clinical presentation, as we have discussed in this patient in our case. First and foremost, clinical presentation. Indralai Surnos ke kaam se. Second is that in the clinical presentation, we must ask patient a history of vaccination. Someone who has taken 3 doses of DPT will never suffer from diphtheria. Please remember it. Someone who has taken adequate vaccination with diphtheria toxoid will never suffer from diphtheria. So if the patient gives correct history of that patient has taken DPT, then your diagnosis cannot be diphtheria. You have to look for something else. But if the patient doesn't give history of vaccination, the diagnosis will be more or less confirmed by your clinical presentation. And then once we obtain the specimen, we isolate the organism, study the colony morphology on the spatial medium, do the fermentation reactions, and determine that it is Corynebacterium diphtheria. But we have not yet shown that it produces toxin or it does not produce toxin. So we also have to do a test to determine whether toxin is produced or not, and that is done by 2 tests, which is known as Corynea strip test, which is for rapid diagnosis, or there is a toxin production test, which is called as Alex test, where there is an agar immune precipitation test. A beautiful diagram of this is given in your book, where a strip of tissue, a strip of paper is impregnated with antitoxin, and it is placed on the culture medium, blood agar, where the bacteria is grown. If the bacteria produces toxin, the toxin will diffuse, antitoxin will also diffuse, and at the point where they will meet, there will be precipitation. So this is Alex test, very nicely demonstrated in your book. Please read in detail what is Alex test for diagnosis of toxin production. We also can demonstrate the cytotoxic effect of the toxin by adding the toxin into the tissue culture and seeing that the cells die, and then adding antitoxin in the tissue culture and showing that this antitoxin protects the cells. We also can do guinea pig inoculation animal test, which we used to do when we were students, but these days this test is not very well done because of consideration for animal health. But theoretically, you should remember that there could be toxin production by elect test or tissue culture, or by guinea pig test it can be detected. But nowadays we have got much more sensitive, much more faster methods of PCR. As we have understood that toxin is produced because of the tox gene, and tox gene is present in the genome of the bacteria. So if we do a PCR, we can detect the presence of tox gene. We can tell that the tox gene is present, so bacteria must be producing toxin. And this test can be done within 6 hours. So it is much faster than Alex test or guinea pig test or tissue culture test. So that's how we diagnose diphtheria. This is the demonstration of the LX test. This central strip of paper contains antiserum, and these are the strains which are being tested: strain number 1, strain number 2, and strain number 3. These bacteria produce toxin, and the antitoxin comes from here, and when they diffuse, they form a line of precipitation. Here, toxin is infiltrating on this side as well as this side. Therefore, we see this line of precipitation here and here also. Similarly for this organism, but this organism, there is no line forming like this, no line forming on this side. So this organism is non-toxin producing, while these organisms are toxin producing organisms. These days this test is not done, but it is interesting to know how we can use the principle of antigen antibody reaction for demonstrating toxin production. Treatment and prevention. I think today we have overshot. It's already 11 o'clock. So we will stop here. We'll discuss about treatment and prevention of Corynebacterium diphtheria infection and diphtheria disease. Now there are two things. One is infection and one is disease. So we'll talk about both things in the subsequent class. So far, we have tried to tell you as to how is diphtheria disease occurring, which is the organism which is involved into causing the disease, and how we can prevent, how we can diagnose and treat the patient. We'll take on these things in the subsequent classes. So far, any doubts, any issues, any questions to anyone?
No, sir.
No? Okay. So here is one interesting photo about which we are going to talk next year or next class, not next year, next class. Balto, the Siberian husky. There is a monument in memory of this animal. So maybe you can Google and find out what this is about. Will that be interesting? So find out something about Balto, and we will discuss about treatment and management and prevention of diphtheria in the next class. Okay. Any doubts? Any questions? Note them down and we can discuss them. Thank you very much. Stay safe, enjoy, and take care. Bye bye.
Thank you, sir.